Hi everybody. Hi everybody, how are you doing? I'm not normally that epic sounding. I will use the laptop. Slightly Titan-esque. Hi everybody, how are you doing? Welcome to the very first School of Health and Wellbeing inaugural Christmas lecture. Thank you very much for coming along. So the idea for this lecture today was to do a lecture which could be understood by anybody, really. So it's an interesting area, which I hate to be very cynical and cliched and use a Glasgow Uni slogan, but is genuinely impactful and world-changing. So it's something that is a very hot topic just now, where research plays a significant role in what we do in terms of public health. The idea of an inaugural Christmas lecture came from the University of Edinburgh, which for a number of years have done these Christmas lectures, which take a complex topic and try to share it with everybody. I think fundamentally, if you want something done really well in Glasgow, start with it being done well in Edinburgh and go from there. So we're going to do better. No, I shamelessly stole that nice idea from Edinburgh. So the speaker today for the first inaugural SHW Christmas lecture is Professor Willie Stewart, who's going to talk to you today about head injury, sport and health. So a nice story from my interaction with Willie, who I've worked with for years now, is a couple of years ago we were at a conference called Neurotrauma. And Willie talked about some of the research he'd done, some of the things that we're doing just now, some things in the future. And I remarked afterwards, you didn't talk a great deal about some really significant papers you've done. If I had a paper in the New England Journal of Medicine, I would not shut up about it. But he barely mentioned it, which to me was very impressive. And I remarked this to him and he said, if you see a director interviewed, for example, they don't tend to talk about what they've done in the past. It's about what they're doing now and what's next. It's about the future. And I found that really inspiring. So, fortunately today we are signed by Rosie Beveridge, who's doing a fantastic job as a British Sign Language expert. So a bit of a bio. Dr. Stewart is consultant neuropathologist at the Queen Elizabeth University Hospital, Glasgow. He holds honorary associate professor status at the University of Glasgow and the University of Pennsylvania Department of Neurosurgery. He leads an internationally regarded research laboratory engaged in multiple programs investigating pathologies of acute and long-term survival from traumatic brain injury. Working with the unique and comprehensive Glasgow TBI archive, Dr. Stewart's research describes the complex neuropathology of brain injury across the range of exposures and survivals, with a particular reference to the link between TBI and neurodegenerative disease. Dr. Stewart directs the field study, which aims to describe lifelong health and dementia risk in former soccer players, and is co-PI in the multi-centre collaborative research programme, Connect TBI. So if you, ladies and gentlemen, assembled guests, if you will please welcome to the stage Professor Stewart.
Thanks very much, Donald, and it's obviously a delight and an honour to be along to give this presentation today. And Rosie's going to do a fantastic job of trying to translate my gibberish into sign language, and I apologise in advance because this kind of thing has happened once before, and I felt really for the person trying to do the translation. I do tend to go off script slightly. Just before I start, one or two disclosures always worth mentioning: where the money comes from and who we talk to. For the purposes of this talk, the ones in red are probably the most relevant. These are sports organisations and agencies that we as a group have worked with and been funded by and spoken to over the years. But I think you'll see in my talk, or I hope you'll see in my talk, that this doesn't in any way influence our approach to research or the way we communicate it. I also should disclose that this work is only a very small part to do with me. There's actually a much wider and far smarter team of individuals involved in the research. On this screen, just to take you through, there's John McLean and Katie Stewart. Katie Stewart, no relation, who work for the Scottish Football Association, are really integral to interpreting what we do. We've got Donald, who you've just heard, who occasionally wears daft hats, not often seen in a suit, we have to say. Danny Mackay, who is often seen carrying a bottle of champagne and otherwise not here. Jill Pell, who points out to me I didn't get authority to show this picture beforehand, didn't get consent to show the one, but I'm sure she won't mind. because she's not cycling across America, she does some research as well. And then Emma, who was a PhD student with us, who's now a research fellow and responsible for a lot of the hard graft on this work. Now, the idea in this talk is I'm going to take you through a process of how we take an observation, something we've seen in the field, in our work, in our everyday practice, a pathology in this case, how we try and understand that pathology and then turn it into context for what it means for the wider public. And then based on what we get from that context for the wider public, how we turn it into some sort of policy, put it into practice to try and either prevent or modify how we're related to disease. But before, this is really high risk talk. I decided for Christmas I'm going to put the boat out. So before we start, I've got a couple of questions as we go along. And if you've got a smartphone, you know how to use them, then you can scan this QR code. And there's a question there, which would you rather train with today, a boxing glove or a football? It's a really simple question. The reason I've got these in, I'm glad I put these in, is because that hot chocolate, if anybody had it, was really, really rich and really sugar-free, sugar-full. And I think if we don't have one or two bits to sort of pep up a bit, everybody's going to be asleep, including me, quite quickly. So, give it a second or two. Interesting. This was worth doing. Not the result I would have predicted. Because in essence, I think we're all familiar with the story. So we're going to say that swings towards people. A lot of people would like to go out with a boxing glove. I don't know if that says a lot about Christmas stresses or pressures. We'll come back to it maybe a little later. I mean, in essence, we're all familiar for many, many years about the anxieties over boxing and what it might lead to in terms of brain health, lifelong brain health. And this dates back almost a century, where original observations described what was then known as the punch-drunk syndrome of, if you can imagine, a long career boxer with a slurred speech and slow thought processes and difficulties with memory and slightly broad-based, slightly staggering in their walking. That described the punch-drunk syndrome. And that really remained a boxer's problem throughout all of last century. Really something that we felt was purely a preserve of boxers. We described some pathology associated with it in the latter half of last century. But because we thought this was a boxer's problem, we thought we'd be smart and call it dementia pugilistica, which is just a fancy way of saying boxer's dementia. And that was probably a mistake, because when we describe it as dementia pugilistica, I think we as researchers just shut down and thinking this probably isn't a problem for anybody else, just for boxers. But that changed in about 20 years ago, when a colleague of mine in Pittsburgh was doing a post-mortem examination on a former American footballer and saw what he thought looked like dementia pugilistica pathology. Boxer's dementia in a footballer's brain, an American footballer's brain. And this man had a decline which fit with what we thought was dementia pugilistica. But of course, you could call it dementia pugilistica because he wasn't a boxer, he wasn't a pugilist, he was a footballer. So he dug around in literature for a better term, and this term was chronic traumatic encephalopathy, or CTE for short. So with that observation of CTE, he felt that the world would take note, American football would thank him for pointing out a problem in their sport, and the sport would change. But of course, it didn't quite work out that way. And if you're looking for a movie that's not Christmas related, there's a movie called Concussion with Will Smith. On Netflix, I think still, so you can watch that and they tell you a bit of the story behind that first CTE case. Now, at that point, as a pathologist, CTE, dementia pugilistica, was something we would see occasionally, but we didn't really know how to describe it. So, John and I, if John was a pathologist, he and I would be looking at a case, and I'd say, well, this looks like dementia pugilistica, and John would say, well, why? Why does it look dementia? I don't really know. It's just, it fits in my mind. We had no real definition. So what we had to do was create a definition. And to do that as pathologists, what we do is we share slide material around of what we think is the pathology we're talking about. And we spend some time looking at it, and then we get together in a place, in a room, and we debate it for a couple of days. And we sometimes argue and sometimes agree. And at the end of a couple of days process, we have a definition which we think defines this pathology. And in this case, what we felt was really distinctive about this CTE pathology was these brown blobs that you can see in the brain sections there. And this is an abnormal form of a protein in the brain called tau. And tau protein is also present in Alzheimer's disease, but in this case, the way it deposits in the brain, these patchy brown deposits at the depths of the folds or sulci in the brain, the depths of the folds in the brain, and particularly circling around about blood vessels, these kind of holes in the sections are little blood vessels. So that patchy brown deposit of protein, that patchy deposit of abnormal tau protein at the depths of the folds of the brain around about blood vessels define the disease for us. With that in mind, what we then do is we go to our own laboratories, our own mortuaries, we start looking for it. Where can we see this pathology? And when we do that, what we find is that what we thought was just a problem of boxers, if you know what you're looking for and you look for it, you find it's present in American footballers, rugby players, wrestlers, ice hockey players, basically in lots of circumstances where the common denominator is head injury exposure, repetitive head impact exposure, contact sports, and in some circumstances, road traffic accidents. So traumatic brain injury is the denominator there. You find it in virtually no other circumstances. And in the 1 or 2%, less than that, of cases described globally where people think they're seeing CTE, but there's no story of brain injury. The reality is that the story of brain injury has just not been gathered from those individuals. So it could be a lady whose brain was donated for dementia research, and there's got patches of what might be CTE, but there's no story of brain injury has been gathered there. But for all we know, they played football or there'll be other circumstances for brain injury. So virtually every single case described, there's a story of brain injury, which is really quite distinctive. Where does it begin? So many of the cases I see are from gentlemen who played football or rugby and who die with a dementia illness. But actually what we know is with dementia illnesses, degenerative brain diseases, they begin decades before patients come to clinic. Decades before. And in fact, with this pathology, we can detect it in the very young. So here's a case where I was asked to re-examine a case from the late 90s, of a 23-year-old rugby player playing at a reasonably high level, who during a match was involved with a collision, got briefly knocked out, managed to convince those around him that he was fit enough to stay on, stayed on, and the next play unfortunately collapsed and never regained consciousness. And in reviewing his brain, there were a number of things we saw, but the important thing is what we saw when we reviewed his brain was this patchy brown deposit of abnormal phosphorylated tau in his brain, round about blood vessels at the depths of sulci, typical of CTE. So there, 23-year-old, evidence of this pathology is already there. So we know it begins early. Now, would he have gone on to develop dementia? I have no idea. We just don't know, but we know the seeds of that disease are there already at 23. What else do we know about it? Well, this again is a series that we published, Donald and I published just a couple of weeks ago. This gathered up all the rugby union cases, brain examinations that have been done in the last 20 years or so. And what we found in this was that what set the cases where we could see CTE, this head injury associated pathology, apart from cases where it wasn't, just how long they played for. So the more rugby you play, the more likely you are to develop this pathology. In this series, around about 20 years was on average for the players that we saw CTE pathology in, about 12 years on average for those that we didn't see CTE pathology in. So this is a pathology unique to head injury, head impact exposure that begins while people are still playing the game. And the longer you play it, the greater the risk there is of getting it. Now, the tau pathology, this CTE pathology is really important. It tells us it's distinctive, it's unique to head injury, but there's lots of other things happening as well. There's a whole other lecture about everything else we see as pathologists in people who've had exposure to head injury, head impact. And if you name a dementia syndrome you might be interested in, then we can really talk about the pathology that's exaggerated in people with head injury. So Alzheimer's disease pathology, exaggerated in people with head injury. Vascular pathology, exaggerated in head injury. But the distinctive, unique pathology is the CTE. Okay, so that is the pathology component. If that's the observation we made, that this pathology was really distinctive in individuals who participated in sport who had history of head injury. And for me, that's fascinating. I'm a pathologist. That's the kind of stuff that I really, really have an interest in. But of course, for everybody else, they say, so what? It's just pathology. What does it mean? Has it got any significance at all? Do these people with a story of head injury, head impacts have any more risk of disease, or is it just a funny pathology they might have in their brain? So we attempted to address this, and it's quite a difficult thing to do, I'll be honest, because what you need to do is have a good population of people who you're examining. So if we're interested in footballers, we need to know lots of footballers, and we need to know as many of the footballers in that population as possible. In other words, we have to know every footballer that's played in the game so we can study them properly and get a sense of what's going on. Now, we're fortunate that up in Hampden, there's a man who's very interested in gathering information on professional footballers and has a catalogue of every professional footballer that's played in Scotland going back to the early 1900s. Gold dust for research. So he agreed to share that with us, which allowed us to then go and identify the health records, because in Scotland we all have an electronic health record. So we could then go and identify those footballers' health records, but more importantly, we could identify the health records of people in the community who hadn't played professional football, but were born in the same year, we're all men, so matched on sex, and we're living in much the same areas. So we looked at postcode level social deprivation. So we had a really quite a good matching population. For every footballer, we matched them with 3 population controls. Now, I'll just take you through this. This is the paper that Donald referred to. Let me take you through it quickly. In some respects, there was some good news, because we found out that these footballers, by and large, when we looked at the causes of death, I looked at mortality in them, we had slightly lower mortality. And for some causes of death, they were actually doing a bit better. So they had less cardiovascular death, less lung cancer death. So in some respects, these were healthy men. But the counter to that is when we look at their neurodegenerative disease, which is just a long word for dementia and associated illness, we find that the risk of developing that was much higher than we'd expect, about 4.5 times higher than we would see in our matched population group. So there's something there. That's a really quite a dramatic increase in risk. Now, I told you though that they had less cancer and cardiovascular disease. These are kind of common causes of death. So maybe as one of the biggest risk factors for developing dementia is getting old. Maybe all that's happening is our footballers are preferentially getting older. So this is just a phenomenon of healthy older age that we're picking up. So we can adjust for that. We can adjust for the cancer and cardiovascular risk being slightly lower. And when we do that, the risk drops from 4.5 to about 3.5 times. So in other words, even adjusting for living a bit longer, we've still got this much higher risk of developing degenerative brain disease. And when you look at the types of disease, it's not just one thing. It's not just dementia. We also see high risk of motor neuron disease. It's about 4-fold higher risk of motor neuron disease if you played professional football, and about a doubling of risk in Parkinson's disease. So again, it comes back to repeatedly banging your head over and over again. We hypothesize is a risk at this stage. And we know the pathology in these individuals carries this very distinctive protein in the distribution that's related to head injury. Another question for you. Which is heavier? The old style leather football or the modern synthetic football? And if it helps, I didn't clear this with health and safety, but I brought one of each along. I get to choose who heads it. So which is heavier? Old style leather football or modern synthetic football? Real science here. What's that? Don't get smart with me. Just answer the question. We'll come back to that. So which is heavier? And this is important because we need to think about like risk and how risk might change in the years. We all just about had a go. So what do we think? The answer, most people say 2/3-ish, the old style leather football. Okay. Those very balls, I weighed them at home. I should have brought the scales in, but I weighed those very balls at home. And would you believe they're exactly the same weight? 427 grams. There you go. So the modern synthetic ball weighs the same as the old style leather ball. We'll come back to whether it's wet or dry. The reason that's important is because what we then wanted to do, once we'd identified that footballers had a higher risk of degenerative brain disease, we wanted to look closer because our hypothesis is this is something to do with head impact. Remember the pathology? It's distinctly head impact, head injury related. So now the question is, do you see any relationship between the dementia risk and features to do with head injury, head impact? So you learn a lot about football. I'm really a rugby man. But you learn a lot about football when you start doing this research. And one of the things we learn is that your risk of hitting a ball, or the likelihood of you hitting a ball, varies depending on which position you're in. So if you're a goalkeeper, for instance, you don't head the ball much. Your head injury risk is much lower than anywhere else. If you play in defence, you hit the ball a lot, and your head injury risk is higher than other positions as well. So, taking that, we'd expect the risk of dementias to be lowest in goalkeepers and higher in outfield players, and particularly so in defenders. And sure enough, that's what we find. In fact, goalkeepers' risk is about the same as anybody else's. It looks slightly higher, but when you adjust for that living longer, remember living longer is a risk for developing these diseases, you adjust for that, you find actually the goalkeeper's risk much the same. But the defender's risk is much higher. It's about 5-fold higher. Second thing is, if this is a problem to do with something in the sport, so heading the ball, head injuries in sport, then you can dribble them along the ground. Then we'd expect the risk to vary depending on how long. Oh goodness, depending on how long. This is now getting quite. We'd expect the risk to be greater the longer you're exposed to the sport. So if you have a really long career, your risk is high. If you have a really short career, your risk is not that high. And sure enough, we find that as well. The longer you're exposed to football, the longer you play professional football, the greater your risk of developing these diseases. And that goes with the pathology. We don't remember what we said, the longer you play rugby, the greater your risk of developing the pathology. So we're beginning to see the patterns emerge through this now. And then finally, coming back to these balls, is that one of the arguments we hear is that the ball technology, the changes in the game would have reduced the risk. So the modern synthetic balls are lighter, feathers and fly through the air. The old leather balls are heavy. And so the modern lightweight ball is less of a risk in some way. Well, we've just shown that they're exactly the same weight, and that's regulated by the rules of the game. And actually, it was pure fluke that they're exactly the same weight, because they could have been a few grams either way, and then I'd have lost my bet. If the old leather one was 428 grams and the other one's 427, you'd all been right. In fact, they're both the same. Yes. Couldn't have done it. Could have done it if I tried. You're right that the old leather ball, the reason they changed them is that the old leather ball used to soak up water when it got wet and scuffed up, and it did change its weight marginally, a few percent. But the important thing is the impact that if I were to throw the ball at Rosie's head, or I would, if I were to throw the ball at Rosie's head, the impact she feels is more to do with the speed the ball is moving at than its weight. And when you get that leather ball heavier and wet, it travels slower through the air. So actually, the heavier, wetter ball will probably land with less impact because of lower speed than the modern synthetic ones. So modern synthetic ones are probably more of a risk, arguably. Anyway, all that aside, when we look at the risk over time throughout the whole of last century, it doesn't change. So no matter what ball technology you're talking about, the risk is much the same. And we did a similar thing looking at rugby players, far fewer rugby players to work with. These are international level rugby players, and we find that the risk of degenerative brain disease is about 2.5 to 3-fold higher. Again, there's that variability depending on which diagnosis we're looking at, particularly in motor neuron disease, but that's probably a quirk of small numbers. The message is contact sports, impact sports are a risk for brain health as we go on in life. Now, again, presenting that data, we think that should be enough. Sport would be delighted. We've told them something important. They can change. They can make it safer for players. And there's a group called the Concussion Sport Group who meet every 4 years and are lightly put experts within the world of sport who meet every 4 years and decide what we should worry about and how we should manage concussion. Now, the levels they set for evidence are that they must be the highest level of evidence. So what we call systematic review. So You do lots and lots of research. You design studies where John and I, who are virtually identical in every way, he will head the ball for 10 years and I won't head the ball. And at the end of that 10-year period, we'll do some tests and then we'll follow each other for 10 years and then 10 years and then 10 years until eventually John develops dementia and I don't. And we'll say, well, there you go. It was the heading what did it. There's a bit of a problem with that because clearly setting up a 50-year study, brilliant for research, if we can get it funded, we'll start it today. But setting it up is really tough. And of course, lots of things happen in life in between time. John could take to the drink more than he does normally. I could become a sloth and not engage in physical activity more than I do normally. So lots of other factors come into it. So it's not really practical. So that level of evidence is tough to meet on something like this. But the current concussion sport group's view is that before they worry too much more about dementia and sport, they need longitudinal case control studies. That study where John heads the ball 10 years and I don't. They need the genetics thought of, levels of education thought of. They need socioeconomic factor. You name the risk factor, you name the influence, and they want it all thought of before we're going to get too worried about the risks in the sport. Now, let's just talk about those other risk factors for dementia. Head injury is one. It's an important one. But there's a whole bunch of other things as well which influence risk of neurodegenerative disease, like cardiovascular disease, like smoking, like obesity, etc. So we've looked at that in our former footballers. Just to answer that question, are all our former footballers alcoholics who smoke like chimneys? Well, probably not, because they don't have lung cancer, so they're probably not smoking. But let's just look at it anyway. This is quite complicated, so I'll skip over most of it, but effectively the green means that footballers are doing well. Footballers are doing better than the people in the population we're comparing them to. Whereas grey means they're no different in the population. And so when we look at all these other modifiable risk factors for dementia, what we find is that our footballers, by and large, are doing better. So their levels of overweight, well, they're not, they're less overweight than the population. They get less diabetes in the general population. They're not smoking, less alcohol disease. So all these things are in their favour. So by these odds, our footballers should have less dementia than the general population, not more. Yet what we're seeing is footballers have more dementia. So there's something else which is influencing risk of dementia. Footballers, I'll bring you back to its head injuries and head impacts. So healthy men should be expecting long and healthy lives with little to no dementia or less dementia, and they're not. Now I'm just going to flip it slightly just to make sure everybody's still awake. I'm now going to show you something about arthritis in footballers, just because we're kind of stubborn on this one and it kept coming up. And so we thought we'd look at the data. So in the same population of footballers, we looked at data on arthritis, and what we find out is that former footballers have a much higher risk of arthritis of the lower limb than the general population. Does that surprise anyone? Are we surprised that former footballers have degenerative joint disease in their knees? Mostly. Why not? Because they get repetitive knee injury, repetitive knee impacts throughout their whole career. Many of them retire because of it. So of course it makes perfect sense that former footballers would have degenerative joint disease because of repetitive injuries and impacts. Of course it makes perfect sense. Is anybody an orthopedic surgeon or a physiotherapist or anything like that? You know, safe. Because knees are really simple. Really, really simple compared to brains, which are fabulously complicated and very, very, very delicate. So if it makes perfect sense, logical sense, we can all accept that footballers would have a higher risk of degenerative knees because of repeated injury and impact. Why is it so hard for some people to understand that repeatedly impacting and injuring your brain could leave you with some lifelong problems? And that's the challenge we've got. It seems to be so hard for people to grasp that concept. But brains compared to knees, night and day. So go back to this for the concussion sport group's gold standard. This very, very high level of evidence that they demand to see before they make any changes. I would suggest that in this respect, there's probably a fool's gold standard. It's really not acceptable practice. And what we really need to be thinking about is, particularly when you've got something where cause and effect are decades apart. So 23-year-olds playing rugby now could be talking about lifelong disease 40 years from now. So when they're so far apart, then you really need to operate on the basis of precautionary principles. So is there something we can do to reduce the risk, which isn't going to actually in itself cause more problem? And it seems quite simple. Stop banging your head, stop injuring your brain so much. It seems pretty simple. And that's unlikely to cause any lifelong damage or any immediate damage to anybody. It might mean that there's one or two less goals scored. I doubt it, but it might. But is that really going to harm anybody? So that's the question we've got. So that's the second part of this, if you like. The pathology observation, this funny thing we saw, which seemed to be related to head injury, and now putting it in a population sense. What does it mean for the wider population? What do we think is happening here? The next thing is to take that and turn the evidence of what we think is the cause into some practical application. So if we know the cause of what's happening, there's something we can do to prevent it. There's some way that we can somehow reduce the likely lifelong consequences of brain injury. In some respects, it's too late, but it's something we can do to try and reduce risk. Why is this important? Well, does anybody have any idea who this is? No, Josie. You like it? On the left-hand side, this lady here is a lady called Auguste D. And she was, if you like, the first case of Alzheimer's disease. Which obviously wasn't the first case, but she was the first case described of Alzheimer's disease, because that chap up there is Alzheimer. And he was convinced that what was going on with this lady was not, if you like, a functional disease or a kind of psychiatric disease. He was sure that what was happening, there was something structurally wrong in her brain. He was convinced of it. And so he persuaded the family that when Auguste died, could he look at her brain in great detail and see if he could see what the problems were. And he did. And he looked down a microscope and he saw what we now recognise rolled over as Alzheimer's disease, with, apart from Josie's answer, we get neurofibrillary tangles and amyloid plaques. And that gave us the first understanding that actually dementia was a disease of the brain. There was things happening, the structural changes in the brain which were leading to this condition. That was over 100 years ago. This slide now is populated with all the drugs successes we've had in 100 years for treating Alzheimer's disease and dementias. None. So we spent 100 years, and I know you say, well, hang on, there's been headlines recently, but let's just wait and see, because they're producing marginal research effects on limited outcomes. So let's just wait and see. There are no, after almost over 100 years of effort, we have nothing to show from research in dementia change disease at this stage. The reason for that is, so this is slightly complicated, but let me just talk you through it. So we've got here two pictures of brains of people with brain injury. One where it was a younger man who died pretty soon after the brain injury, within a day or two, quite a severe brain injury. But the only evidence of that brain injury, when we look at his brain, is a little bruise there, which is probably invisible to you back in the room. Tiny bruise inside of his brain. But when we look deep inside his brain with a microscope, we can see all sorts of damage down the microscope. Okay. Here on the right side is the brain of a man who died 20 years or so later from a very similar injury. He survived the initial injury, but died about 20 years later. And if you look, he's got a little bit there's an old bruise which is healed on the side of his brain, virtually in the same place as there. But if you look at the brain, he's lost a lot of tissue, so that brain has atrophied, as we say. And if I were to put those two brain slices down in front of colleagues in pathology and say, what do you think was wrong with the patient on the right, they'd say, looks like dementia, looks like a degenerative brain disease. But this is just trauma. This is just a brain injury. This is a severe brain injury, not a rugby brain injury or even a boxing brain injury. This is a severe trauma, a road traffic accident type. And what we think is happening behind the scenes with normal aging, as we're all getting older, we've got this slow accumulation of pathology. This is just getting older. We all know, as you know, every year is another tussle. You know, we're getting older. Things are slowing down. Things are getting harder. So we believe that what happens is we accumulate pathology in our brains, and eventually we get to a point where that pathology leads to dementia syndrome. For some people, that can be in their 80s. Some people in the 70s. The pathologies vary. We're not being specific here. We're just saying that as we age, naturally we accumulate pathology. What we believe happens in trauma is that you shift the curve. So you have an acute pathology, you have acute injury, which gives you an immediate change. And then when you recover, you don't quite recover back to where you were before. You recover at a different line, which just means that you cross that threshold towards dementia slightly earlier or slightly more frequently than we would expect. So that changes your risk of dementia. Now, the big problem, going back to dementia research, is that for pretty much a whole century, our research has been focused on this bit, people who have disease, who've got very late stage pathology, who've already got established Alzheimer's disease or established vascular dementia. At that point, if I were to look at their brains, they would be ravaged with disease. What we're suggesting is probably a better place to target our efforts is to look at decades before the disease presents. So by the time somebody has disease, they've already got significant pathology, really hard to treat pathology. But maybe if we could get them 10 years or 20 years or 30 years before, some of these fancy drugs we've got might work even better than they do now. So that's the challenge, not to wait for disease, but get in early before the disease starts. Now, this brings up an interesting concept then of thinking about our athletes, our footballers and rugby players in three ways. We think of them when they're playing the sport. What can we do to change their risk while they're playing sport? That's in the obvious place. This is a preventable dementia. It's not banging your head. Then we've got to think about what happens when they finally develop disease, if this happens. And that's really about recognizing the condition. So currently I will have, when brains or people come to communicate with me, often they're told that their father, their husband, who was a footballer who now has dementia, won't have CTE because it's such a rare disease. But it's actually quite a common disease amongst footballers and rugby players. About 3/4 of the brains I look at of dementia, of rugby players and footballers with dementia, have CTE in them. So it's quite a common disease. So we need to get better at recognizing it and supporting people with this condition. But importantly, in the middle, in this midlife slice of the pie, which is most of the people who've participated in sport and haven't yet developed dementia, we need to think of ways of changing course of disease there. So that's a focus of research. Let's work out in midlife, long before disease symptoms might emerge, what can we do to improve their brain health, to reduce their risk of developing dementia? We can't take the brain injury away. They've had it. Already had the brain injury, already had their impact. So we've got to do something else. Think smart. What are the other risk factors? Now, the problem is we're generally healthy men, we said, so we've got a bit of a challenge, but we'll figure out something. In terms of that primary prevention, rugby is a standout sport. It's very difficult to compare head injury risk among sports because they all gather them in slightly different ways. So American football gathers it one way, rugby gathers it another way, football gathers it another way. So it's difficult to do that kind of cross examination of how the different sports influence risk or risk of injury in each sport. But this has been done by colleagues in University of Michigan. And their kind of summary effectively was, when you compare rugby to any other sport, it's a standout high risk for head injury. So there's a starting point. Rugby's got such a high risk of head injury. Let's just figure out a way of reducing that risk of head injury. That's the starting point. Okay, so let's start with that. Which of these reduces concussion risk? Just making sure you're all awake. Which of these reduces concussion risk?
So more than one. Are we allowed to put more than one?
Yeah, as many as you like, yeah. Female neck strengthening headgear and helmets, good one. Mouth guards.
Synthetic footballs.
Synthetic football, oh yeah. Come on, modern football. Surely. Embarrass myself. Synthetic football, yay! Thank you. All right, are we all had enough here, yeah? Yeah. Had enough. So we think headgear and helmets, come back, that's really important. Female sex, neck strengthening, synthetic footballs and mouth guards. What if I told you I played a trick on you again? And none of these reduces risk of concussion. In fact, female sex, if you play like for like, sport like rugby where the rules are the same, or football where the rules are the same, the risk of concussion is about double in women as in men. So it turns out none of these will change your risk of concussion. These are all false assumptions we've got based on data. And yet we see headlines like this. Parents rush out to buy scrum caps. Rugby's concussion problem can be tackled by smart mouth guards. Why is that? These won't make any difference. The problem in the brain is not the impact, it's the rotation. So it's the brain, if you like, wobbling inside the skull, not the blow of the impact to the skull itself. That's what makes the difference. So almost no amount of headgear will make a difference. However, I'm going to reveal today, I actually have a solution. We're going to have to keep this one quiet amongst ourselves. I have a solution, which I think could just be the breakthrough we're looking for. Give me a second. It's in a kind of preliminary form. No, it's serious. So first of all, we need the headgear. Okay. Now, I was thinking about this. This comes with an extra bonus. Now, I'm not saying this is necessarily going to be in the full final format, but it does come with a whiplash indicator. Suddenly jolts in my head. The coach can see that. So we get that. Now, I know what you're thinking. Apart from this looks daft. I know what you're thinking. This isn't much good because there's not much impact protection here. So we need to build in some impact protection. I'm serious. So we've got impact protection. So now this is just as good as the headgear that we're seeing here, virtually. So it looks good. It's got impact protection, so I'm protecting my skull and soft tissues. Okay. It's got a whiplash detector, which I really hadn't thought of, but I'm going to patent that one as well. But I know what you're saying. It's not by any stretch of the imagination smart. I think it is quite smart. It's not smart. Now, but that what they talk about is it's got accelerometers built in that can detect movements and detect impact. I have a solution for that too. Yeah.
A girl's just walked by and been like, what's going on?
This is genius. This is genius. Rosie's the only one that is protected from this. This is genius. Impact protection, whiplash, and all accelerometers you need. Everything in it. Genius. Now, obviously, it needs a bit of refinement, but actually, this bit, the phone on front, I think is the thing that's going to make a difference above all these other ones, because I'm getting to my point now, because we care more about the welfare, the immediate acute welfare of our mobile phones than we do about the welfare of our brains 20, 30 years down, or at least athletes do. So if you attach this to the front of your boy or girl's head and send them off to play rugby, there's no way they're going to put their head in the wrong place. I got that. What? See? Now let's do that. Right. No, what we're going to do is come up with smarter solutions than that. So not put our faith in headgear that's not going to work, or mouth guards that aren't going to be terribly helpful, or chocolate milk, or high-fat diets, or neck strengthening that's never been proven, or synthetic balls, which are no different to old balls. None of that stuff really helps. We just have to stop it happening in the first place. So many years ago, as an early translation of some of our evidence, we had this thing called If in Doubt, Sit Them Out, which was the first guidance for concussion at all levels in grassroots sports. So table tennis, basketball, football, rugby, everybody did the same thing in Scotland. This was the guidance you went with. And that was launched in 2016. We're now at the third iteration of it, so it's been quite successful. And the latest thing we've been doing is we've taken a bus, the NES. So NHS Education Scotland has a sort of truck which you can borrow if you want to, and take it out places and set it up and have a little, things to do some education. So it's been getting taken out to, in this case, Murrayfield. It was at the UCI Cycling World Championships. It'll be in Scotstoun in a few weeks' time. If anybody wants to come along to that, I'll let you know when. And inside, we've got lots of conversations about concussion and information and leaflets to try and make sure the community gets it. We've also, this is Katie Stewart again. And what they've been doing is they've been going out to PE teachers, and as part of their curriculum, telling them about concussion, how to spot concussion, how to manage concussion, so that if the injury happens, players are removed and the risk of catastrophic injury or perhaps further problems is diminished. They also get a cool t-shirt as well, which is good for photos. Not sure what else it's for, but it looks good. And great success, having done it. Donald said, if an idea in Edinburgh, then pinch it for Glasgow. Well, this is an idea in Scotland, which the UK has pinched. So we were doing this for 6 years, and finally, UK sport has got on board, and the same thing exists now across UK sport. Grassroots concussion guidance for every single sport. The other thing you get to do is some fun stuff. which is you get to hang out with documentary makers, Alan Shearer and Shane, sorry, concussion. So and that might seem like fun stuff, but it's important because people watch Alan Shearer. When the Alan Shearer documentary came out, we spent a lot of time on balance to make sure it was done properly. And when that came out, we had a huge upturn in interest. We had a lot of people engaging with websites and gathering information, wanting to know more, wanting to know how they could change their ways. Same with Shane Williams. So different populations, different ways. And occasionally, if you'd spotted it, you do other stupid things like turn up at a football match for charity and agree to play in goal and get absolutely hammered. It's not something I'll do again. It seems like a good idea too. In hindsight, so I was putting research into practice because remember I said goalkeepers had lowest risk. So I said I'll go in goal. Not keeping in mind that the whole point of the match was that there was no heading in it. So it was a low risk match anyway. And I could have been out and was hidden. And then the other thing is that we start to see sport take this on board and sport begin to change and start thinking about how they can alter risk. Now, the problem is the global sport, concussion sport group, and even global sports organisations are still not absolutely convinced that we need to change. But those that we are nearest to, so Scottish football, Scottish rugby, English football, English rugby, we can sit down with and explain it to them and take them through the data and they get it. And so they're making changes. So we see things like the Football Association changing its approach to heading, Scottish football changing its approach to heading, rugby changing its approach to tackling to try and reduce risk across the board. That's a great win, I think, on our part. Of course, not everybody is entirely sold on these being measures for change, for the good. I mean, you go to your peer review from another place. So you go to social media peer review, and you find that people kind of knock the idea. So unbelievable, absolute joke. I mean, it's a view. And then this one's always a difficult one. Lots of people I know have died of dementia and they never played sport. My kids will continue tackling until the day I die because it's so important to the game. And you've got to sit down with these people to let their brains are quite important too. And we're not talking about all dementia, we're talking about preventable dementia. So let's just work around it. It's sometimes quite tough, but we do our best to get to everything. So that, I hope, is a kind of potted story about how we got this pathology observation, which seemed a bit niche, and we turn it into something a bit more generalised in terms of how it might impact a wider population, probably beyond sport, because we're understanding dementia here. And then finally, how we take that information and try and turn it into practical change. Because ultimately, when it comes down to it, this is potentially an entirely preventable cause of dementia. So we should be able to stop it. And again, clearly you've done any of that work. Most of these people on the screen have done real work. So thank you.
Thank you very much, Rosie. That was fantastic.
Thank you.
Right. Do you have any questions for Willie?
You got me a bit worried. I fell over on an ice rink around 12, 13 years ago and really smacked my head really bad. If I didn't go to hospital, probably should have done. Is that going to start me on that?
No, so reassurance is that when we're talking about this, we talk about a dose effect. And to see the kind of things we're seeing now, you need a big dose of injury. And so a big dose of injury is being hit by a car and ending up in ITU, and recovering over a period of months, if not years. A big dose of injury is playing sport at a high level for 20 years, as we've seen from the rugby data. So that's a big dose of injury. What we haven't seen is good evidence that single milder injury will change your risk lifelong. What we do know is that people can have symptoms for months and sometimes years afterwards of so-called mild injury. But changing your risk of disease lifelong, we haven't got good, strong evidence for that just yet, particularly not in young people, different as we get older, but in young people, we're classifying years. We don't see that. And that's good because I've got my share of injuries. I got off a bike a few years ago and had an injury. And so I'm sticking to the, one or two injuries is probably okay. But we would encourage it.
Thank you.
I think Claire?
Yeah, that was great. Thank you. It was really interesting. Yeah, before my question, when we were at school, we were made to line up in header balls, whether we were interested in football or not, which I never was. So that was a horrible experience, and hopefully they don't do that anymore to children. Yeah, Mike, you've like kind of busted some myths here, because I believe the one about the leather balls. I also thought that the reason rugby was, I know nothing about sport. I thought that kind of the protection of American football, the equipment, is why American footballers had maybe slightly lower risk. But you said the equipment doesn't really help the helmets and things. So why is rugby so much worse?
So actually, it's a really good point. So the first thing on the headers, it's interesting because it wasn't that long ago, you know, just within my lifetime, that schools used a boxing in a curriculum, and that's gone now, because of the awareness that it probably wasn't that clever. But it wasn't that long ago that, as you say, kids were kind of made to head the ball, and that's gone now as well, particularly under 12s. In terms of risk, I took out a slide. We can look at the risk across sports. So if you look at American football, rugby, the methodologies are slightly different, but they're kind of enough to get a broad feeling what's going on. And the risk in American football is at least the same, if not slightly higher, than we see in the rugby data. So I don't think there's anything that suggests that American football is necessarily safe because of the helmets, or that rugby's less safe because of the lack of helmets. It's to do with exposure. And in American football, again, you need to think about the eras of sports. American football in the professional era that these data would come from, which is pretty much all American football that's been looked at, they're training, you know, continuously with direct head-on-head impacts as part of a training regime. So forget heading a ball. Donald and I, if we were training, would do what they call I can't remember, it's a state where I would run headlong to Donald. And then, to you know, simulate the game. So they have very high exposures to a lot of these serious impacts. The data we're looking at in rugby is from the kind of more amateur era of rugby, even at the international level. So they've been training a couple of nights a week and playing on a Saturday, but much less impact. I mean, we're really worried about professional rugby from 1995 onwards, where they started training on professionally.
Add on to the so really interesting talk. Thank you very much. Got a son who plays rugby, and so I'm curious, but I've always kind of convinced myself that he's a back, so he's protected, he's fine. You know, he's got his grooming comb out, he's not in the rucks. So I'm interested to hear you talk about exposure. So I was wondering about whether you have any more nuanced data around frequency of impact, because he's had a long-term exposure, but I'm thinking he's not had many impacts.
Yeah.
So do you have it? I mean, is it frequency?
So again, that's a really good question. We did look at positional exposure or positional risk in the rugby data that Donald and I looked at. Unfortunately, we just didn't have enough numbers to be able to tease anything out of it. And actually, it depends where you're playing in the back line. Which position does he play?
10.
Say no more. So it depends where you're playing on risk of exposure to impacts. We don't have that data. Biggest, because what we're looking at is records data, so health records data. So we're not having an opportunity to ask how many times people might have been banging their head over their lifetime. We even if you get rugby players in and ask them, you know, we know how unreliable that can be. They can say anything from, "Oh, I barely ever hit my head," and then their teammates will say, "But he was the head banger every day. I mean, he was crazy." And other people would say, you know, a winger, you know, I was always running into trouble, where we know they wouldn't have been. So it's unreliable. So the only way to do that, that's probably where the electronics come in, the gum shields, is to actually count up impacts in players and then get a proper measure of what's happening in gameplay, and then direct that towards the data we've got from our research and start to say, well, actually now we know how risk for head impacts positions are. And you can line them up and then start looking at the data on them. So we don't quite have that yet. The best metric we still have, unfortunately, is just years of exposure as a surrogate. There was one paper in football that tried to ask footballers how often did you head the ball and correlate that with risk. It looked like those that said they headed it most probably had a higher risk, but I'm not sure about the way they did that, to be honest.
Susan, at the back.
The headgear not play a part in making it visible, a visible reminder?
No, it's worse than that. So, actually what makes it visible right now, I don't think, is I'm collecting, what we started seeing is that, we can get into youth rugby clubs that they'll put on their shirt if in doubt, sit them out. So they're running around with on. So they Shield winners, Ayr and Wellington School that won the Shield at the weekend had it on their shirt, which is really cool. We just share that with people. What happens with the headgear is that it might be a visible, reminder to the parents on the sideline that their kids' heads are important. But for the kids, it's just an excuse to go in harder with their head and stick it where it shouldn't be. So we've actually got a brilliant helmet built in, which is the scalp and skull. So the skull protects the brain, and the scalp is full of pain sensors. So that if we bang our head, we kind of go, geez, that hurt, and we don't do it again. But if you then stick even just that hat on it, you stop feeling so much pain as you put your head where it shouldn't be. So paradoxically, when you look at the concussion risk in rugby players with soft shell caps, it stays the same, if not goes up slightly, because they're sticking their head where they shouldn't be. So
It would surprise you to know I have been up here on the sideline with a child like one of them ones, but
Yeah.
I have asked that.
I mean, their ears would be lovely, and their scalp will be looked after, but the brain inside is not getting any protection from that at all. So it depends. I'm not suggesting you remove it, but it doesn't necessarily create the protection you want.
We'll take a couple just from Zoom for a wee bit of balance, so they feel involved. So a couple of choice one questions from Zoom, from Philippa. If you had children, would you let them play rugby?
Yeah. So, so whilst we're talking about the risks of head injury and head impact, there's fantastic benefits of physical activity. So if we look at the footballer data we've got, we can do the same with rugby data. Is their hearts are better, their lungs are better, the mental health is better. The knees are a bit messy, but that's the here and there. So their weight's better. So they've got a whole bunch of measures where they're physically healthier, but there's this risk of degenerative brain disease. So what we're really getting to is that if I had, like, my kids wanted to play rugby, and they're past that now, but if they were younger and wanted to play rugby, I would take them along, as I would encourage people to do, and talk to the coaches and teachers. What do you do in football? At what age do you introduce heading? And if they say, well, as soon as we get them 8 years and up, I would just take them down to the next club, because that's not by any means the regulations. It's 12 minimum. Rugby, what do you do about contact training as little as possible? And what do you do about kids who might have a head injury? Well, we take them straight off the park, and we look after them and make sure they don't go back and play, and we'll keep them out for at least 3 weeks. So I would ask those questions, and if you don't get any straight, sensible answers, then just take them to the next club, take them to the next sport. I mean, physical activity is great. Running is great. Badminton is great. Tennis is great. None of them, as far as we know, have a risk of dementia. Banging your head is not great.
So another question from online before we go back to people in the room. Marcus asks, what would you say is best practice for combat sports such as boxing, where blows to the head are a fundamental part of the sport?
And actually, paradoxically, combat sports have got it kind of sussed. They're managing things paradoxically quite well, because I think they could see, when schools were retreating from boxing as part of the curriculum, and when even the military was beginning to turn its back on it, not American military. They began, and the BMA has called for boxing to be banned, and still there on the books. Boxing should be banned according to the BMA. I think boxing said, well, if we don't adapt, we will literally die. So they introduced medical review. So to have a license to box, you have to have a regular neurological review and a brain scan. If you get knocked out boxing, you're out for months, not 6 days, 7 or 2 weeks as it is now in rugby. So actually, they've got it fairly well measured, and people who go into, if you were taking up boxing, you kind of know that there's a risk to your brain. So people are informed, and the coaches know about it, the participants know about it. So boxing's got it kind of fairly well sussed at the moment. And I'm not by any means against boxing at all. I mean, I think it's a crazy sport, but if people want to participate in it, they're actually fairly well looked after. And why not? Whereas in rugby and football, we don't talk about it. I at one point had tried to get people discussing putting a health warning on football, saying, caution, repeatedly hitting the ball may lead to long-term brain health problems. And why not?
There are so many questions here and online that I think we'll maybe set a cap at maybe 4:10, or something like that, because there are so many questions that. Yeah, the lady at the back on the far left, please.
Just wondering about cricket, because cricket has recently introduced the helmets. Have there been some studies in terms of cricket ball impact or?
Yeah, thanks. We haven't, I'm not, as far as I know, that nobody's really looked at sort of brain health, you know, in mid to later life in cricket. I know that the cricket authorities are beginning to ask those questions. The other thing is that, I mean, the concern in cricket has recently been about the acute and severe injury from ball, and with the deaths and serious injuries in the last decade or so. And so they produced quite sensible headgear, but that headgear is there to protect against the direct blow, the skull fracture, and the neck impacts that might lead to sudden death. So that's what the head gear is there. And cricket has introduced concussion protocols, which are pretty much exactly as the UK guidance would have them. So that the lifelong problems with cricket are not known. Baseball, the equivalent in America, the baseball athletes have no recorded increased risk of degenerative brain disease, and they tend to be healthier in later life than American football as well. So my feeling is that cricket's probably not got a problem with late life health, but it does have a concern about the acute traumatic brain injuries.
Gentleman at the front.
Thanks very much. A few months ago, the MRC got in touch with us in the Social and Public Health Sciences unit about an evaluation of the concussion in sport guidelines and the effect they were having on clubs.
Yeah.
And we fixed a meeting with the Department of Health to take this forward, and it was all starting to happen. And then the Department for Culture, Media and Sport got involved, and then suddenly it wasn't happening. Do you have any insight into why they might be reluctant to do that? He suggested that clubs are very variable in the way they're treating these guidelines at the moment.
So what we found, so the reason that we ended up with the Scottish guidance was that we did a thing with a student years ago where they contacted 50 odd sports around the UK, north and south of the border, to find out what their concussion policies were. And we only found 6 associations had anything very useful, or 7. Anything of any use, and they were pretty much rugby and football and horse riding, jockey club. But the jockey club one was concussions of brain injury. That was the only information they had, but it was better than nothing. It was, you know, everyone else had nothing. So that's how we came up with the Scottish concussion guidance. We've been working at that for some time now. The UK concussion guidance kind of caught up with that last year. And in some respects, it's been good because it's got a kind of a single standard that everybody should work to. It's also stopped a lot of research that was going on because, you know, people were beginning to evaluate the success of these guidelines and guidance. And with the intervention of DCMS, they've said, well, we'll direct research from now on. So everybody's hold on, we'll let you know what we need to be addressed. And so I know that what they're doing is just the process of planning, as governments do. And I think there's been a change in DCMS at least once or twice. And we all know what's happening with Westminster at the moment. So I get a feeling it's dropped down priorities. But it'd be interesting, actually, if you've got ideas, we've got possible solutions for funding that we can work on and try and get that done. It'd be really helpful.
The lady.
Yeah, the graph you showed about dementia coming in at later life. So does that indicate that if you just live long enough, because tau seem to naturally accumulate somehow, you're going to get a dementia anyway? Is that like cancer, that if mutations come in, eventually you're going to get it?
Conceptually, although it's by no means a guarantee. So there's no age scale on that. What we know is that the older, so those of us who are older in this room, so let's say we all drop dead, apart from me, because you need me to study your brains, but let's say everybody else in the room drops dead. Someone's going to do it. So let's say you all drop dead and I examine the brains. What we'll find is that in the youngest folk in the room, we'll find probably nothing much unless you've been playing rugby or football. But as we get to the older age, you know, through middle age and older ages, we'll find more and more and more pathology. And we may even find in some of us, there's quite a lot of pathology, although we're all functioning okay. So we know that the older you get, the more pathology you accumulate. And the more pathology you have, the more likely it is you'll have dementia, but no guarantee. So what we can do, what we can see is we can see people who drop dead at 90 who've been doing the Times crossword and their brain is full of pathology. You'd swear they must have Alzheimer's disease, but they've been functioning perfectly okay. So that conceptual graph is that if we did all live with no other diseases and just accumulated brain pathology, eventually we'd get a point where an age is unique to all of us, we develop the dementia. But the way that natural life works is most of us don't get to that age, or many of us don't get to that age, and many of us get other problems on the way through. So, but conceptually, yeah, that's how it works.
Is it one more question in person, then one online? Gentleman in the front.
Yeah, just quickly, so it's two. First of all, from what 15 years, there's no safe way to head of football. What do you think it will take to outlaw anything? And
So I'm glad you brought that up. So we know that the current exposure to heading, and that's the risk in football as far as we see it, is not good. Current exposure to heading. So I was speaking to a family last week, and their estimate was that their husband had head the ball something like 80,000 times over a career. That's 80,000 head impacts, which are fairly minor, but nevertheless add up over time. Probably 1,000 of those, maybe 2,000 of those would have been in a match where people would have cheered it on and applauded it and maybe even scored a goal or saved a goal. But the other 69,000 were during the week in training. So they, stand in line, will throw the ball to you, or as they kick the ball up high and everybody heads it back. Nobody's seeing that. Nobody's paying for it. Nobody's cheering it on. It's exposure to head impacts for the sake of training, in inverted commas. And I'm going to be slightly controversial here and say that heading a football is not rocket science or brain surgery or even epidemiology. It's just heading a ball. It's not, it can't take 70,000 practices to be able to head it once. So we can start very quickly by getting rid of as much of that unnecessary stuff during the week, which Scottish football and English football have done. So Scottish football now, during a kind of average professional week, they're only allowed to head it twice in training, not within 48 hours of each session, no more than 10 or 20 headers in a session, and not within 48 hours of a match. So they just get rid of tons of it. And that was in consultation with the league managers, so they're comfortable with that. So I think we could start with that. And that buys a bit of time to gather up some more evidence about where the limits should be.
so reducing exposure, not removing them. My question is, what do you think evidence is going to be? Smoking, or is the obvious one, big floor study, and the second one, you mentioned the guidance says under 12.
Yeah.
Why did you choose 12? Is it because that's what we were ready for? People will agree to 12 years old, or is it a political reason?
So it's a bit of that. So is there any good sound science that 12 is better than 11 or 13 is worse than there isn't really. But there are natural change. This is where you sit down with sport and you say, like, this is our concern and we need to change. We all need to agree with change. So where does it work for sport? Where does it seem sensible to make those changes? And we did a bit of work where we looked at how much heading do kids do at different ages. It turns out under 12, virtually never headed the ball at all. It was a freak event in a match where it bounced off a kid's head and everybody applauded that accident. And yet when we spoke to some coaches in other countries, they were practicing 80 headers a week. So they were lining the kids up and they were all doing 80 headers because one of them might accidentally get a head in front of a ball. So it seemed easy to say, well, under 12 doesn't happen in matches, but there are great risk of exposure from training. So let's get rid of it there. I mean, I think we're obviously everything's been monitored closely and we're sitting down with sport regularly. I think that as we see successes and failures, we may go back and sit and talk about how we tweak it. So maybe we tweak to an older age, or maybe even do as the government's, I mean, I hate to suggest this, but do as the government's doing with smoking, is that, exposure to heading increases year on year, so that today's 12-year-olds may never head a ball, but it won't be alien to them. I don't, we'll see. But the problem is that the time point between the changes we're making now and currently being able to detect a change is about 40, 50 years more. I'll be long gone. Donald will be hanging on, possibly, but he's not long gone. So we need to make changes quite quickly.
So final question, which is a kind of a segue from that. Is there evidence of any greater risk for teenage brains? That question's from Christine.
Yeah, so I mean, that's a fantastic question. So there is something funny happens in adolescence in terms of the acute injury. So that young lad that I showed who died, he was 23, but he was kind of the top end of the odd phenomenon that happens with brains is the adolescence, teenage years. The reasons we don't fully understand, even mild injuries can result in a catastrophic outcome where the brain just swells uncontrollably. Sometimes referred to as second impact syndrome, and it's fantastically rare. So nobody should be panicking right now about it, but it's fantastically rare, idiosyncratic. But for some reason happens, something about the adolescent brain just being more susceptible to injury in that way. We've got some really good work that Josie's looking at, which looks at the young person's brain and demonstrates that there's some quite interesting differences in the young person's brain, the way the blood vessels respond to injury, which might be behind all this. So I think teenage brains are quite susceptible because that's when a lot of this sport happens, which is even more reason to be ultra cautious and have that if in doubt sit about.
Right, well, ladies and gentlemen, if you please. Patented Stuart helmet.
You saw it here first.
Pending, no photos, please. And if you please give me a warm round of applause for our British Sign Language support. I'm sorry we didn't get through all the questions. We would be here all night with all the questions, but we hope you will join us next year for the Christmas lecture again. And have a lovely break. And thank you for coming. And thank you again to our two individuals at the front. So thank you very much. Nice. I'll mute that. There were so many questions online. That's it. Thank you, everybody online. See you later.